We'll start here with slides. So I do have a royalty issue with Arthrex with this topic, as everybody knows. I've helped design this, but I've been a proponent of this for a long time. And so the real thing is, why should you be doing arthroscopic lateral ligament reconstruction, right? We've seen the open, and people say, hey, they do okay, but really, they don't do as well as everybody thinks they do. The study says, well, all my brostroms do great, but the data doesn't support that. The reality is that about 5 to 10% of people don't do well. They either have recurrent instability or they have residual pain. That's what the data shows. There's intra-articular pathology, and the reality is you can't see the medial aspect of the joint through that lateral incision unless you want to make a really big incision. And so it's difficult to know what pathology is over there. And so many of us know that there's intra-articular pathology in patients with ankle instability. Dr. Ferkel has shown that, and he demonstrated that in his talk. And so many of us are doing arthroscopic exams prior to our lateral ligament reconstruction. We saw Dr. Watson take down the leg out of the leg holder. So, if you're not scoping your instability patients, you probably should be doing so. And if you are scoping them, then why not just do the lateral ligament reconstruction when you're doing the scope? Why sit down and take it out of distraction or take it out of the leg holder when you can do it right then and there? The second reason is that the arthroscopic brostrom procedures do better than everyone thinks, and they do remain stable. The biomechanics show that it's equivalent to open techniques. Is it as good, is it as, quote, strong as putting a large piece of shoelace in there? No, it isn't, but it is equal to the open techniques. There's greater than 10 published studies that show equivalent, if not better, clinical results with open techniques with patients anywhere from 24 or 16 patients in one case to 286 patients. There's meta-analysis that have shown no significant difference between open and arthroscopic techniques. And in March of this past year, the open results were actually worse, that arthroscopic results did better in the long term over a 12 to 24 month time period. The third reason to do it, it's faster and more efficient in the operating room. Open ligament reconstruction takes time, whether you're reprepping and draping or you're taking down the leg from the leg holder. You have increased OR time, water extravasation. Frankly, I can do this procedure in about 8 to 10 minutes. And so after I've scoped the ankle, it takes me about 8 minutes to do my procedure. There's obviously a learning curve with this, but my previous time between scoping and then taking it down, doing the opening, the incision, closing the incision in layers, et cetera, takes about 25 to 30 minutes. And you get excellent results in the operating room, substantial improvements in your instability, and you can see this arthroscopically while you're looking at it. So you can actually know for sure that you've got things tight and they're not over tightened. What's the fourth reason? Well, there's better patient satisfaction. They have less pain, which obviously in this era means less opioid use, less swelling, there's less incisional scarring, and they recover faster than traditional open brostrom procedures. They have faster recovery times. You can see there's hardly any swelling in this patient first post-op. By 6 weeks, there's none. And by 6 months, you can't even see the incision. Here's a patient 6 weeks post-op who's walking just fine in a regular shoe. So he's not running like that diver, but ambulating just fine without a problem. Is it because there's better proprioception due to less disruption of the overlying soft tissues and nerve supply? It might be. I don't have data for that, but that's what I would, when you're not disturbing normal tissue, you're going to have better results than when you disturb a bunch of normal tissue to get to the abnormal pathology. And finally, it's almost 2021. We're just a few days away. But every other major joint specialty uses the arthroscope much more effectively than we do in foot and ankle. And so we need to really move into the real world, into what are other people doing. You can miss pathology if you don't look in the joint. There's less pain and swelling in the other joints when they do their surgery this way. They have equal clinical results and higher patient satisfaction. So, we're at a point now where I think we should be doing these fully arthroscopic. We don't need to be making, quote, large incisions anymore. If you made an incision like that on the shoulder, they would laugh you out of the operating room. They do distal clavicle incisions through the arthroscope. Why we're not doing these ligament reconstructions through the arthroscope is beyond me. Don't be fooled by the skeptics who say you need fancy magic potions and magic and things like that to get better results like the internal brace. You can just use a regular brace like everybody else uses that you can buy over the counter. It's much less expensive than using a sterile brace in the operating room and inserting it into your leg. And so, the studies show that the clinical and biomechanical results are equal. It's safe, it's stable, it's simple, and patients are satisfied. So fully arthroscopic procedures are the way to go. Remember, what is tradition? It's something new that stuck. And so in 20 years, this will be the tradition to do arthroscopic procedures. So when you have patients like this, are you going to go back and use all these old-fashioned techniques and these old-fashioned devices, or are you going to move into the 21st century and do these arthroscopically? Thank you very much.